everybody. I welcome you all to this lecture series of Association of Child Neurology for Pediatric Neurologists. And today we have a rather different kind of a subject, uh, which is traumatic brain injury, what a pediatric neurologist should know. We have with us the very well-known and experienced Dr. Alcy Torres from Boston, who will be delivering this talk. And we have Professor Lin from Myanmar, who will be chairing this session. And Dr. Vipin Walia, I have invited him because he's a very well-known and renowned neurosurgeon and very active in the field for his expert comments at the end after Professor Lin has summarized. And at the end, we will have the question answer sessions. So welcome everybody. And let me introduce Professor Lin. Professor Lin is the Senior Consultant Pediatrician and Consultant Pediatric Neurologist at the Yangon Children's Hospital in Myanmar. He graduated from the University of Medicine in Myanmar in 1993, and he was elected as a Fellow of the Royal College of Pediatrics and Child Health in UK in 2013. He's currently holding many positions. He's the president of the Myanmar Pediatric Society, General Secretary of the ASEAN Pediatric Federation, General Secretary of the Myanmar Epilepsy Chapter, Chair of the Long-Term Planning Committee of the Asian Oceania Child Neurology Association. His main interests are developmental pediatrics, epilepsy, and brain infections. And he has many publications and awards and has made many presentations in international conferences and meetings. I now hand over the proceedings to Professor Lin.
Thank you, Dr. Mehta. Good evening, everyone. Welcome to AOCN Web Academy on the topic on the traumatic brain injury. So as we all know, the traumatic brain injury is quite an important cause of morbidity as well as mortality in children. As pediatric neurologists and also as general pediatricians, we need to know how to differentiate minor brain injury from the moderate or severe injuries. And also we need to know how to acutely manage a child with a brain injury, including when to do neuroimaging, when to refer to neurosurgery, and when to admit, and etc. Not only recognition and the treatment, we also should be familiar with some subsequent management like post-concussion management and also rehabilitation as well. So today we are quite fortunate to have our honorable speaker, Dr. Alcy Torres, who is going to talk on the traumatic brain injuries, what pediatric neurologists know. Dr. Torres, he received his MD degree at University Central del Ecuador in 1990, finished pediatric residency at Carlos Andrade Marine Hospital, Quito, Ecuador, and Nicholas Children's Hospital in Miami, and neurology at the Longwood Neurology Program at Harvard Medical School. He then completed his pediatric neurology fellowship at Boston Children's Hospital, Harvard Medical School, where he remained on staff for 13 years before becoming the director of pediatric brain injury program at Boston Medical Center. Currently, he is an associate professor of pediatrics and neurology at the Boston University School of Medicine. He has been recognized many times by Boston Magazine as a top child neurologist in the region. He is also the author of over 128 peer-reviewed publications that focus on the diagnosis and treatment of severe pediatrics and the neurological conditions, especially on pediatric concussions and the long-term effect of the repetitive head injuries. He is also a member of editorial board of the most prestigious journals of the specialty in the USA, particularly the Journal of Pediatric Neurology, Child Neurology, and many others. And he's involved in the national organizations, including Child Neurology Society, American Academy of Pediatrics and Brain Injury Association, as well as some international associations and organizations like International Child Neurology Association, ICNA, the Ibero-American Academy of Pediatric Neurology, etc. So he has won several awards and teaching and mentoring of early career clinicians and investigators. So thank you, Dr. Torres, and may I respectfully invite Dr. Torres to give a talk on the traumatic brain injury. Thank you.
Thank you. Thank you very much, Dr. Lin, for your very kind introduction. And let me see if we share my screen. Okay, do you have it now? Can you see? Can everybody?
We can see. Yeah, we can see you.
All right, very well.
We can see the screen. Yeah.
Okay, excellent. So first of all, it is an honor to be here this evening to talk to you about traumatic brain injury, what the general pediatric neurologist should know. And I would like to thank Dr. Rekha Mittal for her kind invitation, to Professor Lin for being the moderator, but also to Dr. Walia, who is here with us tonight. Before I start, I would like to present my solidarity with the Indian people for the victims of COVID-19 and my wish for better days for you and the planet that we share. So I don't have any financial disclosures for this talk. However, I must tell you that I'm a member of several organizations that are related to traumatic brain injury. The experts group in Massachusetts, it's a branch of the Department of Public Health that advises on policies about traumatic brain injury here in the state. I also advise to the Wesley United Soccer Club, and I'm a member of different organizations and boards related to concussion. But perhaps the most interesting disclosure that I need to share with you, it is that I have been fortunate enough to play the sport since I was very young, I think when I was 5 years of age. And obviously, as my South American accent can tell you, it is soccer, but it is my favorite sport. And I was able to play all along from elementary, high school, college, and professional. And then when I came to the States, I developed some coaching skills, and I coached for 18 years teams of boys and girls. And this allows me to see this with a little bit of a different perspective, if you wish. So today, our learning objectives are to describe the physiological changes associated with concussive brain injury and how they relate to clinically relevant sequelae, to properly identify and assess the child and adolescent with traumatic brain injury, in particular concussion, to develop a management plan and understand the limitations of the evidence, and to become familiar with available resources and evidence-based guidelines for concussion care. I always like to start this talk with some numbers that give us an idea of, as Dr. Ling was referring to, how frequent this problem it is and how serious. So traumatic brain injury represents about 30% of all injury deaths, and about 153 people in the USA die only for injuries that include traumatic brain injury. Fortunately, most of traumatic brain injuries are what we call mild, and those are the ones that are called concussions. However, this term mild now, it is controversial, as some of these patients have symptoms that could last for months, and some of them even beyond that. Fortunately, this percent of people that develop symptoms that are prolonged at about 15% at the max. However, it's an important part of the population as the cost of traumatic brain injury. Now, concussion incidence and trends in this study in the last 20 years in high school sports reflects some interesting findings. Football is one of the most common and popular sports in America, But it's interesting to see that after some interventions, policies have changed, the rules of the game, especially in the younger population, the rates of concussion have decreased, which is a good thing. However, most of the decreased rate in concussions have been in practice, whereas in games there has been a slight increase. Now, overall, the good news is that all sports concussion rates have decreased in all sports in general, but it is still particularly worrisome that it is still more prominent in girls, especially when we're talking about recurrent risk of concussion according to the study of CARE or only a year ago. Anybody who works in a hospital needs to be familiar with traumatic brain injury, as Dr. Wallia can testify. So in 1 year only in the United States, it's about 700,000 children that will present to an emergency room. From those, about 15% will be admitted, and from those, about 33,000 kids will die. When you look about the percentage, you find out that the percentage between adults and pediatrics is almost pretty similar, 0.4, 0.5. However, when you look at the numbers and you think about that this is a preventable cause, then you think that this is something that requires a lot of public health work still here in the US as also around the globe. We're very fortunate in the institution that I work, we have 50-50 almost distribution between sports-related concussion on your left and non-sports related concussion injuries on your right. As you can see, 90% of the patients that have a sports-related concussion, they are younger than 23 years of age. Whereas in the non-sports category, it is 50-50, and the cutoff, it is about 31 years of age. And why this is happening? So you need to look at traumatic brain injury across the lifespan. And what you see here is that there are 3 peaks. One, the preschooler age, another one, the young adults or adolescents here, and then at the end of life. In the continuous line, you see all along that males are more affected than females, and that if you're a pediatric neurologist, it's interesting, you have 2 peaks here that in both our specialty. But when I started becoming familiar with this topic, it really called my attention at the beginning. Why is that the preschoolers even higher than the risk takers, the adolescents? And then you start thinking about, like, yes, when you are 2 years of age, you don't have a good balance, you are not conscious enough, you are not aware of the dangers, and also, unfortunately, you are more vulnerable to suffer from abuse. And so, these, however, taking together the preschool and the adolescent ranges make this the #1 cause of death and disability in kids and teenagers in the industrialized world. And it is also very frequent in patients that are non-industrialized. It's just that infectious disease is still very prominent in other parts of the world. So now, what are the sex differences? So females had, this is something we have been interested for a long time trying to understand. Females had an increased odds of abnormal. This is one of the tests that we do for concussion, the near point convergence test and the tandem gait. And it seems that females, according to a study published this year, are more affected than boys. In this study, about 38 studies in this meta-analysis reveal that the girls were more affected, especially in 2 sports, soccer and basket. And when you look at lacrosse injuries, this is interesting, comparing girls and boys, it was found, as you can see here, in this picture, you see that the girls are playing without helmets, whereas the boys, interestingly, they do wear helmets. And this is interesting because traditionally we have said that helmets do not prevent concussion. However, when you have a sport that is so violent like this, and you're not wearing any protection, then this study suggests that that might not be the case for every situation. And then I was thinking, in what type of injury do I introduce you today? Do I present? And so you're probably familiar. I know that cricket is very popular in India. In a regular stroll around New Delhi streets, you can find people playing this sport. I remember there was this championship was last year, and they are playing England versus Australia. This is the third test during those games. And on those games, there is this accident that occurred in which Steve Smith was hit very hard by this ball thrown by Archer, this English player. And as you can see here, he's completely down on the ground. There is a slight posturing of the arms. And then usually are the teammates that come to help you better to assess. Then and there are protocols, obviously, in Cricket Association for concussion. Then there is an athletic trainer that gets there, find what's going on. And then this is interesting, right? You think that that player was taken out, right? You probably think that he was not able to go back to play. Most people that have studied concussion will realize that. However, this is what happened. The player went out, was tested, and unfortunately, I'm saying, he passed the test, but the next day he started having symptoms, take another test and fail. So meaning that not because you have no symptoms, and not because you even passed the test, if it was the right test applied, then you're ready to go back to play. The safest thing for these players for not ever have to go back to play. There has been many definitions on concussion through the years, and there was a doctor here in Boston University almost like 80 years ago, Denny Brown, who was an English doctor who had professorships in many universities, Hopkins, Oxford, Harvard, BU, and he already had a definition that is very similar to this. But as we humans are, we always like to reinvent sometimes the wheel. And then pressed by some international organizations, there was a meeting of experts on traumatic brain injury in Zurich they define what it is a concussion. I like to present this definition rather than the American Academy of Neurology or the Sports Association, because they usually mention loss of consciousness on their criteria, and that actually, as you're going to see, is rather confusing. So concussion is a complex pathophysiological process affecting the brain induced by traumatic biochemical forces. It's a form of TBI in which rotation is a very important force, however, not the only one, and that the damage is mostly functional rather than structural. And so this is the next slide you will see here on the right, the FIFA headquarters. This is where these main decisions that control the soccer around the globe are made. This was where the first conference was made. And on the left, this is the lobby of the very nice fancy hotel, the Ritz-Carlton in Berlin, where the last meeting was done. This meeting is done almost every 2-3 years. The last one was at the end of 2016, but the consensus was published in the British Journal of Sports Medicine in 2017. And there were some constructs to help this definition. And these constructs were like, you don't need to have a direct blow to produce an impulsive force that will result in a concussion. And I'll give you an example. There is a patient that goes into a roller coaster. For some reason, lost the restraint that holds the upper body, and then the body, the head was shaking back and forth. And when she comes out of the ride, then she had symptoms already of dizziness and headache, and then they persist. And she developed like several of the symptoms of concussion. She was managed as such, and she was never hit directly on the brain. Now, there is a rapid symptom onset, but it's not on the first day, as we have seen on the example that I presented before. And usually the severity of the symptoms build up on the first few days, and then after that you have a gradual resolution. And standard neuroimaging, for the most parts of the world, still considered normal, although that's a concept that is changing by the day. Now, let's talk a little bit about biomechanics. Because it is past the dinner time in India, I think I'm free to talk about this. But rotation, as I said, was a very important force. Now, where do they get it? They get it about 100 years ago because they were trying to think how do they sacrifice the cattle. And they thought that was very inhumane. And I know that in some parts of the world, like India, even, you know, this is sacred. And so they want to try to improve that. And in trying to do that, they, at some point they realized that if they didn't want to use medicines or anesthetics, they didn't want to do any damage to the animal. They decided to do, they realized that if the head of the animal was not fixed, that they will be able to produce a concussion by an impact to the brain. And Denny Brown, who was here at Boston University in 1941, he developed the first animal model on traumatic brain injury. There was an experiment that I like to talk a lot about. It is a very simple experiment run by Holborn in 1943. He put jello into a plastic model, and he pushed the plastic model, and he then opened the casket and realized that the jello was intact. But if he rotated the plastic model and he opened the casket, then he will realize that the jello was squished, smooshed, and destroyed. He thought this is supportive of the idea of rotation. It's a very bad force for the brain. And he published this study in the Journal of Lancet, not something that will happen today for some of you that are listening to this conversation. Then Omaya and Gennarelli in 1974, they run an experiment with Macacus rhesus monkeys, and they push 12 of them. They push them linearly, nothing will happen, and then they will rotate their brains really quickly, but for only an inch and a half, and they all the 12 were concussed, and they published this study. And so then we have, if I present to you two brains, and you look at them carefully, when we think about concussion, it is that you cannot tell the difference. You're not supposed to see the difference between left and right. And in fact, this is just a copy of the same picture that I just made to make it clear this point. Now, why is that we are concerned more about it? Why is that we're talking and we are invited to lectures and we're talking to students about this? Because we now there have more people at risk. In the town that I live, it is at 26,000 people. About 20 years ago, there were only 300 to 400 children involved in soccer. Nowadays, there is more than 1,800 in the same soccer program. So there's much more, and especially girls more than boys definitely have increased the number of participants. It is also because now we are more aware of what happens if you keep hitting your brain repetitively. There is a cumulative factor. We have published a paper with our group here at BU that try to support the notion that if you, more than concussions, if you just keep hitting, then you might be at risk for something that it is called chronic traumatic encephalopathy. I'll go back to that in a second. And then even though it is rare, but it can happen, something that is called second impact syndrome, when you discharge somebody from the ER, still having symptoms, get another injury, and develop an irreversible picture of increased intracranial pressure and herniation. However, this is rare, and a review by a group of Indiana just found 7 cases reported in the entire literature. So why should we care about pathophysiology? Because it relates to neurocognitive impairments, and it tells us where in the process the patient is in terms of recovery. And so this is an old friend, this is the neuron, and we're gonna hit the neuron with, not necessarily now with something like this, right? It could be indirect injury. And so then we have a ionic distribution, potassium out, sodium going in, and in trying to compensate that, we'll use a lot of energy. And this energy, trying to reestablish the energy, but at some point runs out of fuel, the mitochondria is very stressed, this opens the calcium channels on the axon, and then the proteolytic enzymes get activated. And that means that if the axons are damaged, it cannot pass the electrical impulse to the next neuron. There's also significant release of glutamate and an excitatory amino acid that explains why seizures can occur at this point. And then obviously the patient is slow, cannot function very well. We'll go back to that. This is the animal model that we have. We have two, one big, through blast and another one through, this is something called a fluid percussion animal model. As you can see here, it's important to assure that we are giving the same speed and the same impact to the animal. We try to reproduce here, this is the skull. We try to reproduce what will happen even if you're wearing the helmet. The animal gets hit and then there is a rotational force we're trying to mimic in here. And if I show you a video of the animal, then you will see that how ataxic and how druggy the animal has become. This is another way of seeing this neurometabolic cascade, and I want you to focus on glucose going up first and then going down for a long time. And then I want you to pay attention to when the body feels that there is a problem, then it decreases the cerebral blood flow. The problem is that if you do that, then for the areas that might have been affected, and people that work in a stroke knows this very well, there will be less oxygen and less glucose, and you don't know sometimes whether that make it better or worse. Now you hear that we need to be more cautious when the younger population, and sometimes arbitrarily or some sports organizations have put a line at 12 years of age, and you're trying to understand why is that, where is the information, where it comes from, then you realize that a lot of the neurodevelopmental milestones that we have are completing by the age of 12. So if you think about volume of the hippocampus, of the amygdala, the gray matter, the thickness of the cortex, the maturation of the white matter, in particular the corpus callosum, because of the size is very good for study these myelination patterns. Then you realize, look at the years, this has been studied for the last 30 years, but put them together suggests that obviously the more immature you are, then you might be more susceptible. Now, when the injury happens, this usually there are no doctors available, right? It is most of sports organizations in children around the world are run by, if anything, by volunteers, and they cannot be charged with the obligation to diagnose a patient with that. But obviously, the optimum will be that the patient with concussion is being evaluated in the silence. Now, for those ones that are worse, they will be transported to the emergency room where the medical evaluation, the first medical evaluation, sometimes comes into place. And this is important because it allows you to make a diagnosis, and the decisions in terms of workup are specifically to rule out an acute problem like bleeding, right, that you don't have time to miss, and then you will invite Dr. Wallier, the neurosurgeons, to help you out, but also to decide who is going home and who's not. Now, when they don't get better, and then pediatricians or pediatric neurologists dealing with these patients, then they arrive to your clinics. If you have an expertise in traumatic brain injury, and then you have the benefit that you can perform your neurological examination that is still very powerful as it was 100 years ago. But sometimes these patients are tricky because they come with a severe injury. Only a week ago, they tell you that they are perfect and that they want to be clear. And then you need to have a little bit more support to actually prove that that is true. And so that has required that we, the concussion specialists or traumatic brain injury clinics, including their armamentarium, some type of neurocognitive testing. And there is this computerized test here, but if you don't have access to that, that's still okay. You can still have some baseline based on the SCAT-5, for example, that is free of copyrights, and you can download it from the website anytime. But sometimes you still need to have neuropsychology support. If you're lucky, if you're the one that is in the silence and you are going to perform the evaluation, then there are some specific instructions for you. However, before that, I want to tell you that in Massachusetts, for example, it was decided that it was too much responsibility. So the law here says, and it's a very wise law in my opinion, is like if you suspect that a kid, a player, an athlete has had a concussion, you need to pull out the player and he should not return on that game. Then obviously if you're the doctor, you can do the rest of the evaluation. And you're all familiar with mental status questions, but it's interesting, this neuropsychologist from Australia, Maddox, he realizes that at least in young kids, in adolescents, if you ask who is the president, then they might not even know that. And that those questions are not really very helpful, rather than how much is the score, who scored last, who are we playing with, who did we play last week. Better questions, better sensitivity to screen for this disorder. And then if you are a volunteer or as a doctor, as a matter of fact, or coach, then they should need to do certain, they have certain obligations to document, communicate to the parents and make sure that there is appropriate follow-up. Now, in the emergency room, we still use the Glasgow Coma Score, of course, to decide within other means the severity of the trauma. And we have a pediatric version, as you're all familiar with. And I just must say that only in the last 2 years, this has been modified for the very first time in 41 years since this was invented. One of the important things is to make sure that there is no spinal injury. Hopefully that was immobilized in the same field where the injury was happened. And then you have to make sure that those patients that have deteriorating mental status with progressive symptoms, then they might have imaging. But because we are familiar of the risk of imaging these days, we like to apply certain criteria. It doesn't matter which criteria you apply. We like the algorithms of PCARN to decide on imaging on young kids. And as you're probably familiar, this is one of my colleagues also from India who has helped me do a lot of work in neuroimaging and concussion. And we published in 2018 that in patients that have a completely normal exam, even after several weeks, this was a series of almost 100 cases that there were no clinical significant findings encountered. Now, you don't have to use the SCAT-5, other people use other scales, but what is clearly, and it's in every guideline, is that you need to have a scale because there are too many symptoms. There are 22, and there is no time to go one by one. So if the patient feels this, you at least know what are the most salient or the more prominent symptoms you need to take care of. This is a very interesting test because if you don't have an objective, because it helps you to be objective in front of the parents. This is called the BEST test, and it's for older than 13 years old. And it's very simple. You ask the patient to close the eyes, puts the hands on the waist, and in 20 seconds you count the mistakes. And mistakes will be hands off the iliac crest, opening eyes, stumble, moving. You do that also with the dominant leg bended, like in this case. Also, the eyes closed 20 seconds, and then you also do in double stance. And you're allowed to have up to 5 errors here and 3 errors here, but no errors in this case. Now, if you really have to go to a computerized test, the impact test is one of the most worldwide known tests. Unfortunately, it requires registration, it's expensive, it's not easy to get, but it allows you to store all the information and to get it everywhere. So it allows you communication from practitioner to practitioner. And this test evaluates these several neurocognitive functions and will be words that you need to remember, will be shapes that you need to remember, and also with the direction. And it will be shapes like in this case, the yellow ones in the circles and the crosses, that if you see it like that, it appears simple. But if I show you in a few minutes something similar than this, but without the yellow, then you might have encountered difficulties in identifying where were those. And not to say this, look at this, you need to remember these couples. And when it is, even right now, it will be difficult to remember all 9, except for some of you, of course, but it's not easy. And so this is what happens. At baseline, this is what most people function. And if you have an injury, then you see that all the parameters, verbal memory, visual processing speed, and reaction time go down. And in 3 weeks, they tend to go back to what they were at the very beginning. This is what is the natural course for the majority of the people. But you see, it is a reduced neuropsychology testing that is helpful when you're trying to be objective with somebody who might be denying their symptoms. Now, this is not, as you can imagine, this cannot be applied to everybody. And so we asked this year about 270 athletic trainers across the country how they are using this. And it was painfully but understandable that to see that this is impacted. So people that has an economic disadvantage are not having this test as other children. And this paper in this study, they compare patients that have concussions versus fractures. And again, patients with fractures were in a more disadvantage. And then access to flag football was increasing patients that had parents with a better college education. And the only interesting thing was that they didn't find any difference in socioeconomic status in terms of reporting symptoms. But this was one only series, so something that to keep in mind for the future. So now, if we look at the neurometabolic cascade, can we actually understand the symptoms? So ionic flux will be responsible for migraines, altered transmission of the electrical impulse for a slow reaction time, axon injury for impaired cognition and processing, mitochondrial neuronal involvement will produce this vulnerability for second impact syndrome, and the damage of the neuron or the disease of the neuron will be responsible for chronic problems. In terms of management, if you look at what we tell the patient, if I show you this slide 5 years ago, we probably didn't have exercise in here. But now we know that if we don't do exercise as a therapy, then we will not be doing any good for the patient. So rest is only good for the first few days, 2, 3. Then hydration, sleep is key. Otherwise, you don't help these patients. And education, reassurance. They want to know that they are going to get better, that this is not the end of life. When you remove a cell phone these days from an adolescent, it sounds like at the end of life. And then you have to work with the family and everybody else involved, because if you fail on this communication, then you will not do good in your treatment. The message is positive. The 90% of these almost 3,000 college student players got better in 3 weeks. However, this has been questioned by a study performed by an Australian group this year that claims that this might not be that real or truthful when it comes to younger people. In the immediate injury, you know that there is a risk for seizures because of the release of glutamate. And sometimes it's tricky, the diagnosis, especially if they present not at the very beginning, not even in the first few days. Some of them might present weeks and months later, and some of them up to 15 years later could still be related to that. Now, the causes are different. At the beginning is the inflammatory process. On the long term is the scarring that might become an epileptogenic foci. And so you have 4 different types of seizures. One that is very difficult to diagnose, it is the subclinical seizures. Patients that have severe traumatic brain injury and altered mental status will need to go into a unit. And look, this is in a small series, but interesting. Up to 40% of these patients with severe injuries had early post-traumatic seizures. From those, 14 patients, is about 16%, have also subclinical. And from those, 7% of the patients have only subclinical seizures, meaning if you don't put an EEG, you will miss that completely. Now, this will be worse in kids that are younger age, that are being abused, shaken baby syndrome, or they have an intraaxial bleed. Now, MRIs have improved constantly, and for a long time, they have been able to diagnose contusions in the frontal and the temporal lobes and anterior part, or diffuse axonal injury. That's not new. But what might be new for you is these PET studies showing the hypermetabolism of glucose at the beginning of the injury. You see in yellow and red, the activity is pretty high. Then it goes down, remains blue for a long time. And only a year later, look at this, 11 months, 12 months, it starts to recover the same color. And this is independent of the Glasgow score. So there is a profound reduction in glucose metabolism after TBI, even without loss of consciousness or coma. This is another type of imaging called diffusion tensor imaging, allows you to see the white matter tracks pretty well. In adolescents with even mild traumatic brain injury, there was proved that there is abnormalities with diffusion. Now, diffusion is being measured in terms of fluid anisotropy. Here are the controls. And the more symptoms you have, you're going to see that you have more problems with diffusion. This is on the left brain that correspond to an NFL player, American football player, and this is the control. And if you can see here in the temporal area, you see that the entire temporal tract is missing. This might explain the emotional part of the patients that experience chronic traumatic encephalopathy. They are doing very well in terms of what people might think is successful life, yet they feel incomplete and they sometimes commit suicide. You can see there are some problems also in the frontal and parietal. So seeing is believing, used to say St. Thomas, and so here it is. We have now the possibility of doing PET and spectroscopy to check on the mitochondria, DTI and magnetoencephalography to check on the axons, functional MRI, magnetoencephalography and spectroscopy to see the propagation of the electrical impulse, and an MRI to look at chronic problems. So we do have some acute markers that help us predict who is going to do better than others. And in this case, we do have we look at the initial symptom score based on those questionnaires that I mentioned to you. We have prolonged loss of consciousness, amnesia, the people that have multiple injuries if they were not removed before the play. Or we also have long-term considerations, a history of a previous concussion, ADHD, psychological problems or migraines. They don't do too well. You can almost predict that they're going to take some time. Now, why is that we like them to get better before they get injured again? Look at this study in animals, right? Here is the injury. Here is the depressed metabolism. In this experiment, the mouse were allowed to recover before having another one. If you compare this shape to this, it's pretty much the same. Now, what happens if you injure before they heal? And so look at this. It takes a long time and to recover, and then the symptoms might be worse. This is a slide I'd like to share even with patients. If you go to the gym, sometimes you get that experience, you feel well after the exercise. And it is because, with many reasons, there is an increase of brain derivative neurotropic factor in normal people. You can see that. So if what happens is if you send them too early to go back to play to these patients, they don't do too well. And then if you send them too late, they also don't do too well. So what is right? In this study, you can see that if you send them too early, they don't do too well in neurocognitive testing, as well as too late. So you need to find the exact day, the best day, which is usually a few days for the patient, just after 4 or 5 days, maybe for the majority, to find the right place for sending back to some type of exercise. It doesn't have to be heavy. It could be just aerobic, but is enough to help you on the recovery. Now, the NMDA receptor was considered the IQ genes. It has two components, NR2A and NR2B. And after concussion, there is a decrease of NR2A. What about if you would have a magic drug that will replenish NR2A right away? So here is the controls. You see that there is depressed activity in patients that have TBI. This also happens on the hippocampus. There is decreased activity when you compare here in the control to the patients with TBI. What about if you have, this is a drug that used for tuberculosis. And as you can see here, it was used to treat this problem. And in animals, they found out that they were able to improve the concentrations of NR2A, meaning maybe this was a way to help us. However, in the experiments on humans, didn't work so well, so this has been abandoned by the group of California. When the patient goes back to normal, to sport or to regular activities, well, when they are normal cognitively, physically, and if they got a neurocognitive testing. But normal, even if they are normal, you don't send it back to do, to take an SAT exam. You don't send it back to play the last play of the most important championship of your life. It has to be gradual. And once you are recovering academically, then you can consider physical. And then if they check that without producing symptoms, then they can go back to regular life. Now, when you do it, you should communicate with the coaches or with the people involved about what you want, in which state they are. No activity or light aerobic exercise. You want them to have a heart rate that increases. You want drills of a sport that are little by little more complex. So when they are ready for train, when they are ready for games. Now, concussions are only the tip of the iceberg. Eric Pelly is an 18-year-old young boy who was very good on sports and unfortunately had several concussions and died because of a second impact syndrome. When they did a brain biopsy, they encountered this black material deposit on the brain in between the cortex and the subcortical tissue. These are deposits of tau, just like plaques of Alzheimer's. And this is a marker of CTE in a very young guy. Now, what do we do with everything that we have learned? Has anybody been paying attention and changing the rules? Look at this. We're almost close to the end. I want to show you this small video here. And you can see that after an accident like that, you will think that the raceman died. However, if you see the walls now are caution, the vehicle is developed to protect the brain, and the patient, in this case, this athlete, saved his life. Now, so in conclusion, acute pathophysiology, it is related to early symptoms and shows recovery over a set time course. Many pathophysiological changes can be now detected by advanced neuroimaging. There are still elements of the diagnosis and treatment that require more evidence. And yes, you can develop a concussion program provided that you come with an institutional support and training. I do want to show you, this is the team that we have here at Boston University that works in different areas, clinical or research, and different aspects of different ages, sports, non-sports, rehab, severe, and these are very important collaborators that I'm very fortunate to have in this place. This is Ann McKee, Bob Cantu, and Chris Nowinski. We have the Brain Bank here in Boston, linked to our university, where the studies for chronic traumatic encephalopathy led by Bob Stearns are also done. And on the right, my colleague and friend Lee Goldstein, who works in particular with basic science and has developed the two models that I show you today. In terms of resources, the best one is the CDC resource. There is a program, Heads Up. There is a video of 20 minutes and a test that will give you a certificate that is valid for 2 years. We ask our coaches, parents, physicians in training, anybody who is interested to go there. And don't forget the guidelines that the CDC released in 2018 and the sports organization for pediatrics that has updated the guidelines and make communication as a very important key in terms of the treatment. And the last slide, it is to thank you very much for having been here with us this evening. I want to show you, this was my last trip to India, and I still keep the ticket because it was a dream trip. As you can see, I'm here at the Gandhi's Memorial with my wife on the background. This is the Indian gate in Delhi, and this is a fascinating place and a spot that is historic, built 1,000 years ago between the Taj Mahal and Jaipur. And this is only a piece of my experiences in India. The food, the architecture, but most important, the people made that a marvelous, wonderful experience. I hope you have enjoyed this presentation, and I'm really open to questions at this time. Thank you, Dr. Mittal, for inviting me again.
Thank you, Dr. Torres, for a very excellent presentation. Actually, when you show the photos of India, I also missed Jaipur as well, Pink City. I really loved it very much. I want to visit again. So you talked about the different aspects of the traumatic brain injury, starting from numbers like incidence, age, and sex. And also you beautifully explain about the pathophysiology of concussion and also neurometabolic cascade. And you linked clearly with those pathophysiology neurometabolic changes with the clinical signs and symptoms, as well as the some radiological changes. So these are really useful, and you highlighted we should not forget the pathophysiology, each and every aspects of the disease. And the clinical assessment, including scoring and other clinical signs and skills, are quite important. You highlighted, and also about the management and the some aspects of the management of the post-traumatic seizures, which is also, I think, quite important for pediatric neurologists. And finally, there are some practical points like rehab stages, and also they are very useful in practice as well. So thank you very much again, Dr. Torres, for your excellent talk, including theoretical background as well as some applied facts and knowledge. So thank you very much again. So now let me hand over to Dr. Mittal for Q&A sessions. Thank you again.
Dr. Torres, thank you very much for this very nice talk. Could you stop your screen share, please? Is it there? Yeah. Thank you, Dr. Torres. That was a really nice talk and very informative. I would request Dr. Valia to give his comments on his experiences on traumatic brain injury in different ages, including concussion.
Rekha, thank you, and Dr. Torres, thank you. It was a pleasure. It was a very informative talk. I have been in neurosurgery for about 25 years now. As you very rightly said, neurosurgery has a very limited role in concussion. Most of them, or practically all of them, require conservative management. I'm sure Dr. Lin would face the same problem like we do face in India, that the vast majority of patients, especially in the pediatric age group, with concussion don't come to us. They don't come to hospital at all for want of medical facilities. The probability of a child seeing a pediatric neurologist or a neurosurgeon following a concussion are unfortunately remote. And that's the harsh truth, actually. I work in Delhi, which is a metropolitan city, and it's a private hospital. So about 1% of the population would have access to my kind of hospital. And this is the only kind of people who would, if the child has a fall at school, come back to me and say, no, my child had a fall. And then come back to me later as well. Look, doc, you said my child is well, but my child there's a drop in performance in school, there's a lack of interest, all the symptoms of concussion or post-concussion syndrome that we normally see. But the vast majority of kids that we in our country, unfortunately, do not have access to good advice or good management or how to go about the concussion syndrome as well. I'm sure Rekha would agree on that.
If you allow me, I agree completely, Dr. Walia. I realized that, I have been preparing talks for many years on this, and I have tried to get statistics, updated statistics from the World Health Organization. I have contacted them. I have tried to get numbers from different services. And the first surprise to me was that even World Health Organization don't have an updated data. And when you look at the articles, we wrote a review on global concussion with friends from Hong Kong and Canada. And we realized that the most of the literature comes from Canada, UK, and the US. And unfortunately, there is not a lot of data when you look at the other countries. So you can, and this happens also here. We definitely think that there is an underestimate on the number. But when it comes to the rest of the world, it is even harder to get any data at all. There is some data on motor vehicle accidents, but not even on that one, there is an up-to-date numbers to share. So the mortality and the morbidity of these, if it is number one here, could you imagine across the world? Definitely a problem to consider.
So we have some questions for you from our attendees. So someone has asked how to manage
Reka, the sound, your sound, there's a little bit of background noise.
Turn off.
All right, let's go.
Is that better?
Yes.
Is that better?
Yes, yes.
That was the air conditioner making a lot of noise. Anyway, so someone asked, how do you manage post-traumatic sixth nerve palsy? And should children routinely have MRI and MRV in convalescent period when they have persisting abducens palsy?
I'm sorry, Reka, can you repeat that? Because it's not coming clear.
It's,
Dr. Torres, I think you can read the question in the Q&A.
Oh, yes, yes, yes. Hold on one second.
yes.
The sound is not very clear. Yeah.
Answer, how to manage post-traumatic. Oh, yes, perfect. So most post-traumatic sixth cranial nerve palsy, it will resolve on its own, right? You just give it some time and it will resolve on its own. Now, the majority does it, but once in a while, there is one that it will last longer. However, it is important to differentiate between traumatic versus increased intracranial pressure. You want to confuse both because you can have also a post-traumatic increased intracranial hypertension. And what you have, it is a sixth cranial nerve because of pressure rather than a palsy. But I think I understand the question. Now, patients should not routinely have MRI and MRV. That is, it depends on what the situation it is. Now, if it is what we call persistent, right? If the patient, it all depends on what the course is, the one that is going to dictate this. If the patient is getting better by the day, then you have time. But if the patient is not getting better, not only that, the double vision is getting worse, or the patient has headaches or other symptoms, photophobia, very bad photophobia, or a risk factor for hypercoagulability, and sometimes it's clear and sometimes it's not, then you have to go and look for other things like a thrombosis, as the question implied. Now, prefer AED for seizures? Yes, very good question. There's a lot of new information on that. Historically, fosphenytoin or phenytoin has been the drug of choice when you try to do prophylaxis for only 1 week. However, there is plenty of data right now that will support if you, instead of phenytoin, you use levetiracetam. That will still be okay. And then if we do it only for 1 week. However, it depends on the severity of the problem and severity of the seizures. If they're actual seizures, then we keep them for longer. And then the controversy is a little bit higher because the data is for adults and it's difficult to extrapolate data from adults to pediatrics. And so most adults will do it for months, 6 months, and then in pediatrics it's variable depending on who you ask. But nobody will stop too soon. And some will order another EEG just to make sure that there is not, they can calculate the risk for seizures. But this is an area in which the evidence in pediatrics is not very good one yet. Now, what is your policy regarding administration of antiepileptic? I think no, there is no need to do prophylaxis for mild TBI, as I said, if there were no seizures, if there was not a serious illness that imply that there is a severe risk. And finally, in a child without early PT and in a child with early PT, but no, you don't need to use medications if the patient does not have significant risk factors or had already the seizure beyond the 1 week prophylaxis. There's lots of questions about seizures. And then I think I talk about how long, any specific imaging sequences to order. Yeah, there are. So this is only at the level of research. In regular days, in a regular practice, our emergency room of physicians do not go beyond the regular CT or maybe a fast MRI. But we don't do any, I mean, the sequences are obviously diffusion and susceptibility for bleeding and ischemia on the acute setting. But on the long setting, it's just a regular or a standard MRI will do it. However, there is more than 100 articles in the last year talking about different types of imaging. However, and you might hear about PET scans, PEG, all kind of things like that, but those are only at the experimental level yet. Then diclofenac. Well, diclofenac, it is a NMDA agonist, and so it will block the receptors of glycine. By promoting the NMDA receptor, you will capture the glutamate excitatory amino acid, decreasing the concentration on the synaptic cleft, therefore decreasing the risk of epileptogenesis. But as I said, I don't want you to use this tomorrow in your patients, because when they try to use in humans, it didn't work. The only reason I put them in there, it is because my thinking is in the future, we might have that. We might have an anti-tau protein. We might have something that will help us expedite the, in fact, there is already some treatments for severe traumatic brain injury that you can give in the acute setting that was FDA approved and some people are using. We still have not been using in our ER, but there is, so the future might be there. And then what is the best time to get a CT done in pediatric? Well, the only time that you might have to decide that is on the emergency situation, a patient that is deteriorating, because we are, as I said, even though the risk is not too high, but it is, you have to have a good reason to order a CT because there is radiation. And depending on the age of the machine, you must expose the kid to a larger amount of radiation. You don't want to do that. And then most TBI seizures are falls from heights. How much of these observations apply to this? Okay, so about the question it is, most TBIs in children are from falls from heights. Well, yes, but there are different type of heights. So furniture is the most common one, right? And these kids are younger. And the most important thing to remember here, and there is a paper this year that talks about this, is that you might miss the symptoms because the questionnaires are not built for younger children. So if you have a 2-3-year-old, you might miss all of that. And the patient might actually have a concussion, doesn't have to lose consciousness, and those patients might be underdiagnosed. I think we already answered post-traumatic seizures. And then, how can we do in management to reduce long-term neurocognitive deficits? You start treating the patient actively, so physical therapy, send him to a neurocognitive rehab, depending on the severity, special help in the school, IEPs, supporting the schools, instead of forcing the patient, right? Adapting life to the recovery of the patient. And the patient needs to be your partner because he's the one to tell you how ready he is to take the next step. But I do use neuropsychologists in situations that are very complex. Yeah, so in patients that have other symptoms, like the patients that have headaches, but then in retrospect, they think that there is that they might have had an injury, and the same happens with patients with seizures. Parents will tell you, oh, but might be this fall that he had about 2-3 years ago. That's okay. If the exam is normal, you don't need imaging. If your exam and your symptoms, you just treat as a regular migraine and you apply the decision of headache. You know, when you do imaging for patients that have headaches, right? When you suspect ICP, when there are red flags, patients that are waking up in the middle of the night, vomiting in the morning, double vision, deteriorating symptoms, then that's what we will do. And then the last question it is, do we need to do a CT in a child after head trauma that we suspect a skull fracture? No, I will refer this question of practitioners to the algorithm. You should definitely become familiar with the PCARN algorithm. If you go into the web, it's free. You can just answer the questions and they will give you a score right away. And it helps you to make a very good informed decision, evidence-based, on when to do it and when not, instead of the classical guessing game that we had like 20 years ago. Should I do it? Should I don't? What we know is that the skull x-rays are useless for a fracture, right? We all know that, so don't waste your time on that. If you really think there is a fracture, CT is the way to go. And then about post-traumatic 7 nerve injury, prognosis is good. Is depending on the cause. If you actually fix the cause on time, or if it is idiopathic, most people get better. When there is a cause, when the nerve was sectioned, severe, even if that doesn't look clearly on the MRI, then obviously the prognosis will be more difficult. And I think with that, I answered all the questions. Rekha, do you have any other for me?
Yeah. So, what about post-traumatic optic neuritis? We see a lot of that in severe head injuries. In your experience, they should also be given steroids?
You have to be very careful and not make the diagnosis, all right? But if you think that there is inflammation, then there is no good data in pediatric neurology, but I know that some adults will use steroids. I wouldn't be opposed to that. I think steroids, as you know from the experience on the demyelinating disorders in adults, you know that we only use them to speed the process, not to treat the disease. All right, so the same applies.
What is your take on that? Because I find that a lot of the ophthalmologists and neurologists actually give steroids post head injury if the patient has lost vision.
I think it's rare here with us. It's very rare to begin with, and it will be unusual to go that step. All right, it has to be something like really obvious and that the patient really symptomatic for us to be.
Injuries, yeah, they just come with loss of vision following some trauma.
I'm familiar with that practice. I have seen that in many countries, but here in the States is not a standard of care. It had to be something really gross for us to go through that approach.
So any guidelines on which patients should be admitted for observation?
I missed that.
Which group of children should be admitted for observation following a head trauma?
I'm sorry, can you type it, Rekha?
Dr. Torres, she wanted to know what is the indication for admitting a child with head trauma?
Oh, admitting, yes, of course, yes. The patient that has a Glasgow score that it is below 13, the patient that has persistent symptoms or the deteriorating mental status, that needs to be admitted to the hospital. The patient that is very young or the patient that does not have a good follow-up, doesn't live close to the hospital, there is not a way to assure good follow-up, that's the one that you want to keep. The one in which the history, it is not compatible to what you are seeing, or when you get conflicting history, that is for child protection, that will be another child that you want to admit. Obviously, if there is an abnormality on the CT, you want to admit the child.
So, any comments from our chairperson and Dr. Walia on the question answer sessions?
I think questions and answers covered quite a number of issues, especially many are very much interested in the management of the post-traumatic seizures. So you covered a lot. My question is, if there are indications, for hospital admission, what will be the minimum duration do we need to observe in the hospital?
Once you admit, it depends on the clinical evolution, right? Most emergency rooms don't want to keep the patients for a long time. So a lot of these children that otherwise will be admitted for several hours end up being admitted. If the patient is following the right course, and by that I mean is getting better, it will be easy to discharge the next day with the appropriate follow-up. Now, when I say appropriate follow-up, you have to take it with a grain of salt, because you say the patient, you have this appointment with the concussion clinic, but unless you have a system, that will not assure that the patient will come back for appropriate follow-up. You have to have a system to assure that. And then obviously the patient that end up requiring an ICU or more aggressive services, then that patient can stay for days or weeks in the hospital, right? The worst cases can take weeks before they can go home, and they don't go home directly. In that case, they go to a rehab facility before they can go home.
Thank you.
There's one more
Rekha,
question. Yeah, sorry. You wanted to say something?
Rekha, I was just answering your question regarding steroids in traumatic optic neuropathy. Imaging is mandatory to make sure that there is no compression of the optic nerve.
Of course.
Sometimes we find a fracture or something which is compressing in the optic canal, and then a decompression endoscopically through the nose does wonders. If there is no compression, then though it's wide open. There is no class 1 evidence to suggest that steroids work. That's the same thing for spinal cord injury. However, for want of anything else, most of us would exhibit steroids, but is it scientifically proven? No, unfortunately no.
I agree with Dr. Walia, completely.
We had one more question from how frequent is child abuse a cause of traumatic brain injury in your practice?
Dr. Walia, can you please, because you seem to hear her well.
No, why?
No, she wanted to know how, what is the incidence of child abuse in your practice?
Very unfortunately, very high. There is,
head injury.
unfortunately, very high, and during the pandemic, even higher. This is the one area of child abuse that had actually got worse during the pandemic. There is a paper published by my good friend Biju from the UK during the pandemic that proved this fact. Very unfortunately, this has been an area that is not going down. It is still very frequent in the US. And as you know, the preschool area, it is one of the highest peak. And therefore, when you look at the tables in the US, even during the first year of life is in the top 5 causes of death. And when you look at the first 5 years, between 1 year and 5 years, number 1. And from those, unfortunately, it is up to about 3–5% is child abuse. It's very significant, and that might be higher. It's just that underdiagnosed.
I think we don't have any more questions. And I would like to thank Dr. Torres, Professor Lin, and Dr. Walia for being with us here today and for taking on the questions. And it was a very difficult topic and covered from A to Z by you. Thank you, Dr. Torres.
And thank you very much, Rekha. I appreciate it. Thanks a lot.
Thank you, everyone. Pleasure to be here.
Thank you, Dr. Walia, for being the translator, and Dr. Lin for being the moderator. Thank you all.
Thank you.
It was a pleasure.
Bye-bye.
Take care, okay?
Take care,
Bye-bye
stay
now.
healthy.